Dr. S.K. Matseki
originally called Lesedi Clinic, was built in 1985. So as clinics, we decided that it's important to change the facility as time has gone by. We've invested quite a bit of financial capital into improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labor ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. You know, these facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labor ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. You know, for women who'd like, you know, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, you know, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they're working perfectly.
Good evening, and thank you very much, and welcome everyone to our webinar organized by Clinics Health Group, which is a health group that is based primarily in the previously disadvantaged communities. We have got 5 acute hospitals based in Soweto, Dr. S.K. Matseki Memorial, which you've just seen, and also September Hospital in Dobsonville, Soweto. We also have another hospital, Naledi Kanyezi Hospital, which is in Sebokeng, and a Butselong Empilweni Hospital, which is based in Vosloorus in Ekurhuleni. Then we have one other hospital based in Mahiki, Northwest Victoria Tokole Hospital. We also have a combined rehabilitation center, and also patients that were previously at Life Sidimeni, and also a rehabilitation unit and wellness unit at our Solomon Sticks Memorial Hospital, which is based in the CBD, Johannesburg. And we also have a day hospital recently opened last year, GMPG Hospital, which is based in the CBD also. And then our US hospital, also in the Wellness Hospital, which is Kalinin Wellness Hospital, based in Pretoria. And so this is who we are, and we are presenting this weekly webinars since the beginning of the lockdown, when we were all not able to meet physically. So as Clinics Health Group, we then said we will be a thought leader in terms of medical education and supporting healthcare providers in providing quality healthcare. And so we have these webinars where we get experts in their own fields across various disciplines, not only medical, but also other health related disciplines. And so this evening, I just want to welcome all participants who've been with us since the beginning of the pandemic or the lockdown, and special welcome to our guests from other healthcare groups or other professional associations. I've seen quite a number from associations, and also from the Department of Health, those who are joining us following our guest speaker, and also to welcome our senior managers from Clinics Health Group who are here both from the hospitals and also from our corporate services head office. And also a special guest for this evening who is with us that I will introduce a bit later on. Just to indicate that when you join in, make sure that you mute yourselves, the audio, and also switch off the videos. And during the course of the presentation or discuss conversations, you can write your questions on the chat box there, which will be entertained at the end of the presentations. And ensure that when you register, you submit all your details, because if you are registered with either the HPCSA or the Nursing Council, the Pharmacy Council, or any other association that requires CPD points, please indicate and make sure that you give us your details, your email address. As for those with the HPCSA, you don't have to submit your points. We'll submit them on your behalf and they will be registered with the HPCSA. Because these webinars are CPD accredited. And also note that these webinars are recorded. We are live on YouTube. And at the end of the presentations, like tomorrow, we'll be sending you the link so that if you're not able, if you want to follow up on these discussions, you can then go back and view the recording as we are live on YouTube. And so this evening, we're quite excited to receive all of you, to welcome you to this live webinar, as we welcome Dr. Nicholas Crisp, who's a medical doctor and a public health specialist who has for many years focused on health management consulting across the African continent. He was the HOD or Superintendent General of the Department of Health and Welfare in Limpopo, where he served from 1995 to 1999. And Dr. Chris was then a self-employed consultant and has worked on many projects in several African countries, well-traveled, including our country, Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania. In 2009, he served as a special advisor to the then Minister of Health, Barbara Hogan. He was intimately involved in the establishment of the NHLS, National Health Laboratory Services, the transfer of medical legal mortuaries from NHLS to police to, and the creation of the forensic pathology services, and in the establishment of the South African Health Product Regulatory Authority. We've been talking a lot about SAPRA in the last 2 years or so with the pandemic. He's now employed as the Deputy Director General, National Health Insurance, and like everyone else was diverted to support the COVID-19 responses. And we all know, we've seen his face on television many times with the ministers, and when he was talking to us about COVID-19 and the vaccines. And so it's a great pleasure to welcome you this evening, Dr. Nicholas Crisp, to be our guest speaker and to talk to us about health reforms and national health insurance. Just to indicate to colleagues that Nicholas will not be doing a formal presentation like we've seen with other presentations, but we'll have a conversation. He will speak as he's himself a part of NHI, has been with this creation from the beginning. And so please welcome Dr. Nicholas Crisp as he speaks to us about health reforms and national health insurance. Nicholas, we're ready to listen to you.
Good evening, Ray, and thanks to Clinics Group for inviting me, and good evening to everybody else. I see there are over 300 people, so I'll have to be careful and tell my jokes with caution during the course of the evening. As Ray said, I would prefer to not have PowerPoint presentations where everyone's focused on the words on the screen, and I'd rather talk to you about what is happening, where we think we are leading things, what we don't know, what we do know, and where we are at the moment. And then it's far more useful for me to answer questions that you have, because then at least we have a useful set of outputs of the evening, instead of me just saying what I want to say to you. It can't be a one-way street. But if you'll give me a half an hour or so to just convey the core business of what national health insurance is about, then I'm very happy to take questions after that. So we were in Parliament on Tuesday, where the National Department of Health got an opportunity to respond to the Portfolio Committee's hearings on national health insurance. So those hearings started more than 2 years ago, and COVID slowed everything down quite a lot. But once the bill was published was presented to Parliament and passed through Cabinet for authority to present in Parliament, the process that was followed was for the Parliamentary Portfolio Committee to embark on consultation. 3 different types of consultation have been conducted by them. We in the department do not get involved in actually answering questions or making representations during that period. What happened was they called for written comments, and there were many written comments. I've lost track of how many it was, but over 100,000 written comments. The parliamentary office is then responsible for sorting through those comments, consolidating them, because obviously they have themes attached to them, and they submit that back to the Portfolio Committee. The Portfolio Committee also then went on visits to all the provinces, and they had hearings in 2 or 3 and sometimes more locations in each of those provinces, where they collected information about what people were saying about healthcare generally and about the bill specifically. And then there have been 117 oral representations where groups of practitioners, activist groups, professional associations, political parties, and others have requested permission to make oral representation to the committee, and those were concluded about 2 weeks ago. And we were then approached as the department and asked to make an oral submission in response to what we have heard. So obviously during this process, we've been listening and understanding the themes of what people are asking. Some of it we believe is just not understanding what we are trying to achieve, and some of it is fundamental ideological difference, and then some of it is concerns about content and others. So I'll go through some of those with you, and starting off by saying, what are we trying to achieve with national health insurance? What is it? Well, at the high level, and I will stay high level until we get to questions, then I'm happy to go into details. But at the high level, what we are trying to achieve is a single health system in the country, a coherent single system. At the moment, our health system is extremely complicated. Even in the public sector, we are 10 different government departments, and some functions are in local government as well. In the private sector, it's financed by 75 medical schemes through over 300 different packages or scheme differences. And there are other, of course, a lot of out-of-pocket expenditure and other products that are now becoming more and more popular that function outside of the ambit of the Medical Schemes Act, and for which we are not grateful, and we think that they are just complicating the situation even more. So we've got a complicated way of paying for our healthcare in this country. And we've also got a complicated way of delivering the healthcare, because the clinical services and the primary healthcare services are delivered largely by provincial governments with a lot of autonomy. So they don't always follow a collective or common policy, and that creates problems for everybody because the patients don't know about consistency. We get tackled legally because of that inconsistency, and there's not interoperability of systems, so the patient, when they move, don't get a continuum of care, even in the public sector. And then, of course, there's the exchanges between the public and the private sector, where patients move between them. So our concern is that the system is complicated, and as a result of this complication, we don't get good outcomes for our care. So the second major objective is to achieve a purchase of, or second major element of what we are doing with national health insurance is to separate purchasing and providing of health services, where the purchaser is this single fund and the providers are public and private clinicians and other entities that provide health services. So that's the big difference. At the moment, in the public service, the provincial departments are the purchaser and the provider of health services, and in the private sector, there is a split between purchaser and provider, but it's very complicated. where we are going at the end of this is that the healthcare services that we provide in the country, and I'm talking about we now, the health practitioners, I'm not interested in government for the time being. We, as health practitioners, when we provide health services, we provide them to people because they need them, and they need them at that time, they need them at that place, and they need them for a specific condition, and not because there's some other pressures of demand or because they can pay, they get the healthcare. That must not be the primary driver, as it is in many instances at the moment. So we are trying to get to a situation where any of us, when we need our healthcare, where we need our healthcare, how we need our healthcare, is prepaid, so that there's no financial burden on us when we finally arrive and have to get that healthcare. So that is the definition of universal health coverage in the World Health Organization, and that is our objective. So this financing change and the systems reforms that are needed are fundamental, but the big question is how are we going to pay for it and who's going to deliver it? In the greater scheme of things, we spend, as citizens and residents of this country, 8.5% of our GDP on healthcare. That is a lot of money. It's around about 500 billion rand in today's rand terms, and comparable with other countries in our same socioeconomic class, that's actually a lot. The problem is that we are performing worse than many of our counterparts and very poorly considering how much money we are spending. And the reasons are because of the complexity of the way we deliver and organize our services, and the way we pay for our services is wasteful and duplicative. So we need to remove as much as possible of that waste and duplication and save that money and then redirect what we are currently spending. So I'll stick with that for a moment, and then I'll go into what are the facets and components of our structure. So we know that this 8.5% of GDP is roughly half already raised through taxes in the public service and spent in the public service. So it's 269 billion rand this year, this coming financial year. And the other 200 and something billion rand, it's close to 250 billion rand in the coming year, is spent in the private sector, either through scheme memberships and pre-financing or through out-of-pocket spending. The out-of-pocket spending is obviously less in rand terms than the pre-financed money, but that is 8.5% of GDP. The challenge, of course, is that the bulk of the population is being serviced with half of that 8.5%. That is paid for in taxes and provided, the services are provided through the government departments of health and funded through the fiscus and the budget. And that half of what we spend is extremely complicated because the money is allocated as part of a global provincial equitable share to a province. And then the provincial legislators carve up that money for their functions that they are currently required to deliver, which include basic education, health, various social services, and sports and recreation and roads and so forth. So there's no single national budget in the public sector. It's an agglomerate of budgets. And in order to overcome the challenges of the gaps that are left in the system, we have systematically in government seen a creation of a range of conditional grants, some of which are still in place and others of which have come and gone. But we have more conditional grants in health than in the whole rest of government put together. And that's an indication that our budgeting system and our public financing of healthcare is not working very efficiently. The private sector, I don't need to say much about. You all know how that works. The medical schemes collect from us voluntarily purchasing products. The problem is that we don't know what healthcare we're going to need, and we can't anticipate from year to year whether we'll have an accident, whether next year's our turn to be diagnosed with cancer. So often we choose the wrong package, or we just financially can't afford a package that we know we need, and then we end up without healthcare when we need that healthcare, and it happens all too often. And then it's complicated because the permissions for us to use that health services are complicated, and to move between services and between the public and the private sector results in us having to get repeats of blood tests, repeats of x-rays, etc., etc. So it's messy. So what we would like to achieve, as I said in the outset, is a single health system that is primarily financed through what we call in technical terms a single payer system with a single fund. Now, no single payer system in the world really ever has only one single payer, but it's a dominant payer, a very dominant player, as opposed to what we have at the moment where the public sector is only half the player. So there will still be medical schemes, but the plan is to systematically have fewer, covering fewer benefits over time. I'll come back to the overtime issue in a moment. So what are the elements that we need to create in order to result in a comprehensive national health insurance capability, and then the services that we're going to buy with that capability? Well, broadly speaking, there are 6 major areas that we are focusing on. The first one, and the one that's of concern and that Parliament has been raised in Parliament many times, is what are the benefits that will be covered by the national health insurance? And that needs to be described in sufficient detail for us as members of society to make our choice about whether we think that the fund is going to pay for the bulk of what we think our healthcare is going to require, or whether we still would choose to purchase some form of insurance for the things that won't be covered by the fund. The bill says, and we hope it stays that way, that once the fund covers that benefit, then the private schemes are not allowed to cover that benefit. So there will only be top-up and complementary. And you will hear a lot about Section 33 in the debates that are going to follow, and you may have already been following this discussion. There is a conflict between Section 33 and Section 82B, where there's an ambiguity in 82B that sort of gives the impression that the state intends that there will be bypassing of this arrangement. That's not the intention at all, and that will need to be fixed in the drafting of the amendments that Parliament will do before this bill is voted on. But the basic intention is that this fund, with our tax money, which I'm going to talk about in a moment, will pay for all of us all our essential healthcare at the point of delivery when we need that healthcare, and we will not be required to pay in at that point. It also says that if we choose to get care that is outside of those benefits, we may do so, and we may insure ourselves to do that. And that by implication means providers may provide that healthcare as well. So the first one is to be clear about the benefits that we are going to provide. So that's like in medical schemes. Thank you for the distraction in the chat. We'll get to that in a moment. When the benefits that are defined by any medical scheme in any package, you have to try and work out what it means, and we need to simplify it. And there are ways to do that, which we have learned from countries around the world, and we'll talk about which countries we've been looking at as well. So the first thing that we need to get clear on our minds is benefits, and then the price and the cost of first the cost and then the price that the fund will pay for the delivery of those benefits. The second one is, who are we servicing? So who are the users? Now, in any environment, if you're a medical aid, you know who your users are because they are beneficiaries and the members of your scheme. In the public sector, it's primarily the uninsured, but not always the uninsured. Of course, there's a large proportion of insured people who also get their care in the public sector. But there are also a lot of people who we don't know about until they arrive. And that's the clauses that deal with the refugees, asylum seekers, and other people who are undocumented in the country. So, but the bottom line is that the state ultimately is responsible, and even now in the law is ultimately responsible for the care of anybody and everybody. So we need to understand who's the user, where they live, the gender distribution, the age distribution, the changes in the profiles of everybody who's a user of our services. And we need to also understand then who's providing the services to them, where they are, how they are organized, and what capabilities they have. So qualifications, physical space, etc., etc. And those providers in the bill and in the Act are of two different kinds. The first ones are referred to as establishments, and the second are the individual providers. So you can be a doctor or a nurse or a pharmacist and be providing some care to a patient, but generally we all work in some kind of an establishment when we are providing care to patients. So that establishment is also of interest to us because, as you've said, you've got these different types of clinics, hospitals, and the other hospital groups in the private sector and individual hospitals also provide different kinds of care. So you won't necessarily find a cath lab or even an obstetric service in every private hospital. Some might be dedicated cardiac or urology or other types of hospitals. We need to understand where those providers are and what services they are able to deliver. The next area that we need to have is the medicines and the other products that are required to deliver those services. And at the moment, the state pays a lot less than you would pay for them, or the private patient would pay for them in the private sector. And the disparities are massive. And they are largely controlled by price and guarantees of volumes. And because the state is able to purchase in such large volumes with such predictability, we're able to negotiate better prices. So in the National Health Insurance Bill, there's a provision for an Office of Health Products Procurement, and it will expand on the capabilities we presently have, where we procure about 1,200 strategic products centrally in the National Department of Health, not through Treasury, like the ARVs and the TB medicines and so forth, but that will be expanded to everything that is in the formulary. The formulary comes out of the clinical guidelines and what is guaranteed to be paid for as part of the package of care within the benefits. We'll come back to how that works, I'm sure, in questions. So the Office of Health Products Procurement will be not just medicines, and even in SAHPRA, these days, the SAHPRA bill refers to health products as well. It includes devices, in vitro diagnostics, and in our case, we will work with certain consumables as well. So the idea is that the NHI will buy nothing. It will only do the procurement. So set the definition of each of the products, fix the providers who are authorized and who have the capabilities of delivering on those products, and fix the prices. There are various methods of price fixing which happen around the world. We, at the moment, use the benchmark method in South Africa, but there are some other blended methods that are used in other jurisdictions which we are interested in and may look at down the line. But for now, we use benchmarking mostly for fixing prices. Even in the single exit price, we do that. So that's products procurement. In order to manage all of this, and because we are trying to steer the spending of health resources into a more equitable way, and to make sure that we don't have unnecessary duplicative spending, we need a comprehensive digital system. Now, the starting point for all of this has got to be the patient. At the moment in the public service, we have a lot of our digital systems that are focused on a disease. So we've got an HIV system and a TB system and a diabetics monitoring and all kinds of different things, some of which are a little bit more comprehensive, but many of which are either single disease or one or two disease specific. And of course, the patients have complex sets of those different clinical conditions at any point in their lives. So, you know, being HIV positive, diabetic, and pregnant at the moment means we have to fetch your data out of 3 different data sets: the DHIS, out of one of the HIV databases, and then a pregnancy-related system separately. That's not efficient, and we don't get a proper patient record. So where we are going with this, and it will take quite a lot of building, is to have a comprehensive digital patient record that pretty much starts from conception and ends with either cremation or burial. And everything that happens in our lifespan becomes part of that life book. And it belongs to the patient, and it's got a number attached to it that no matter where you go in the health system, whether it's a public or a private provider, whether it's in the primary healthcare system or whether it's in the hospital system, that practitioner can access that same record of yours and build on your record. So that would mean that if somebody else has already seen the patient and has placed the patient on diabetic medication, the next practitioner should be able to see that history and not have to duplicate, and you get a heads up on the care that you give to the patient. So building that is a time-consuming and quite an extensive process, and we have components of it already existing, both in the public and in the private sector. And what we are trying to do is understand where the really good elements of that record sit. And so, for instance, next week or the week after, I can't remember the date, we will be participating in the opening of the private sector's health information exchange, which is quite an exciting development. And we have a similar health information exchange in the public sector. And those information exchanges are compatible. And that means that we will be able to exchange data far more easily than we ever have before. During COVID, we were able to get the entire public and private sector to report on common platforms. And in fact, the electronic vaccine data system and the data that we collect in that system is built on the National Health Insurance's hardware and the development software that was intended for this patient record. So we will be able to use what we've learned in that process to expedite where we are going. But we do have to take all the other loose bits and pieces of different records and get them into a common format that's easy for us as clinicians to access. It will take time. In terms of understanding the user and getting the user that handle on their record, we already have the HPRS, the Health Patients Registration System. There are well over 50 million individual IDs in that system. It includes passport numbers and it includes people who have died, of course. So they will ultimately be removed from the system, but we keep them there for a while. That system is being harmonized with Home Affairs, but you can imagine that's quite a lengthy and difficult process to ensure. But it does mean that the identity theft that happens in the country and which we have seen during COVID is detectable, and we are able to make sure we know that we're dealing with the right patient when we see them. Again, these are evolutionary processes, not events. So the digital systems need to be able to, first of all, look after the patient and provide the clinicians with a place where they can put the patient's records. From a health systems perspective, what we need to be able to do is to extract elements of that data that we need for planning. So for argument's sake, back to what I was saying about the various health products, how much of which products are we using where? Which patients are getting them? Are there seasonal variations? Are there age groups and age bands where they are predominant? And can we get better predictability in the numbers we are using for driving prices down in the product environment when we are doing our procurement? Also, if we see a community, because everybody's record is geographically labeled to their own practitioner of choice or the nearest primary healthcare facility to where they live, we will be able to see across communities when, for instance, now in our test cases, we see a whole community where there's no breast cancer. It's not possible. You can only have no breast cancer if there are no women, and even then you would still expect to see a male breast cancer occasionally. So when you see that happening, it means that the diagnosis is not being made, or it's being made somewhere else, and the care is not directly accessible to the people of that community. Now, those kinds of examples I'm giving you need to be automated because there are thousands of decisions to be made all the time. And so the data analytics build on these big data sets using artificial intelligence, and the analytics that are reflected from there are available on dashboards at various levels within the organization. So obviously we would like to have it accessible at facility level, but also at district level, provincial level and for us at national level for national planning. It's also important, of course, if you want to be paid, that there's a digital system that makes it possible to make the payment and reconcile the benefits that a provider has been giving to a user, and I'm using the words that are in the bill, without having to do too much manual reconciliation, except if there's some exception that is thrown up in the from the digital systems. So all of this automation has been under design for almost 5 years. We've had an opportunity to test a lot of it during COVID in a broader sense, not just in micro environments. We're quite excited about the way that it is performing so far, but we've got a long way to go. And I needn't remind you that there are large parts of the country that are still don't have adequate connectivity. So we are working with other government departments that are responsible for connectivity so that we can move a patient's record real time if somebody moves in a rural area to an urban area and back again. Okay, then the next big one is fraud and corruption. We've been asked repeatedly about fraud and corruption, and it's of course a concern to people like me who put our necks on the line with the NHI. It is a big issue, and the most important thing to do is to design out as far as possible the risks that are associated with these kinds of complex systems. Our colleagues in any business will do that. Whether you're in a hospital, whether you're in a medical scheme, whether you're in a private business or pharmaceutical environment, you try to understand your risks and you design your systems to either design out the risk entirely or to highlight it as quickly as possible and moderate it. And that's what we are trying to do at the moment. And the risks are in the patient environment, in the provider environment, in the supply environment. They're all over. It seems to be a common pastime in South Africa. People seem to think it's only in the public sector that theft and fraud happen, but bad news is it happens everywhere all the time. And we really got to start getting smart about how we design it out. So we have a whole unit that just does that. Part of it is the design. And part of it is when you identify that there's something that's abnormal, unexpected, or untoward, we need to be able to investigate it quickly and to refer it to the relevant law enforcement agencies so they can deal with it. And there are many law enforcement agencies, some of which are the criminal justice system, but some of them are in the pharmaceutical environment inspectorate and other inspectorates. So that is the fifth of the 5 big pillars we're building. And then the 6th one is the fund itself. And I'm going to end off just now talking about the money in the environment. So the fund, the actual fund, can't be created until there's an entity to run the fund, but it will be run through, as most of these entities are, like SARS has done and like any of the entities in government, but particularly I'm thinking of SARS and the Transport Department. They run bank accounts in all the big banks, and they have a financial department that is responsible for all the payments and reconciliations. But it needs to be automated as far as possible to the benefits and the providers, so that when an invoice is submitted, and whether it's paid weekly, monthly, or on some other kind of arrangement, that it is not a laborious and cumbersome process that everybody gets frustrated by. So that banking system is the 6th one that will come. Ultimately, when the entity is out of the Department of Health, it will need its own corporate services to pay the people and look after its own IT and so forth. But that's future music and not particularly relevant to you in this particular discussion. So I want to end off with who's going to pay for all of this. So the good news is that there's way more money in the system than everybody thinks. And it's quantifying and working out how to move the money that is the more tricky part. And that is going to take time. And when I talk time, I'm not talking 1 year, 2 years, or 3 years. I'm talking time, long time. This year is the 75th anniversary of the National Health Service in the UK. It gives you some kind of an idea of how long it takes with the changing environment and technologies to get a system that works reasonably well for the environment in which it's intended and protects people's health. So we are not talking short spaces of time. So we are not talking about this year's economy or next year's economy. We're talking medium-term economies, we're talking medium-term changes, and we're talking existing money first. So step one is the 269 billion rand that is currently in the public service, public system. Now, the bulk of that money goes to patient care, and so therefore the bulk of that system will be moved out of the provincial equitable shares into the national sphere, and it will be moved into the fund, and the actions of service provision will be the responsibility of the provinces. So that's the purchaser provider split. And then the fund will use that money to purchase using capitation in the primary healthcare environment and DRGs in the hospital environment. Clearly, these are going to take a long time to put in place and need to be done systematically, slowly, carefully, and over time. I want to emphasize that. The second lot of money that sits in huge quantities, already paid for with our tax, is the tax credits that we get in the private sector. That is worth 34 billion rand this year, and that is money that systematically and slowly can be withdrawn as a benefit, if you like, or a subsidy to those who are purchasing private services, and can go into the pool as more benefits are available to people through the payment of the national health insurance. You don't need that money to be double dipped or double paid. So that's another 34 billion. The third set of money that is already in the tax environment and already paid for by us as taxpayers is for those of us who are civil servants. Our employer pays a sizable proportion, slightly different from one employee to the other, but a sizable proportion of our contributions to our medical aids. That's already been paid for by everybody as taxpayers. And so if the civil service is getting their services paid for through the national health insurance, you don't need to double pay for that money. And the only portion of the money that is privately decided on is the portion that is individually chosen. So, and then there are three other funds that are in the public space: the Road Accident Fund, the COIDA Fund, and the Mines Fund. They have varying levels of already paid for taxes that are paying for those benefits. So there's quite a lot of money. Not all of it can move easily into the national health insurance, and it needs to be done carefully. We do not want to break existing systems in doing it. But that is how one manages any form of reform and transformation. You do it slowly. So that leaves the rest of the money that we as taxpayers, who are earners, who earn money, who have jobs and get paid and paid the lion's share of personal tax. What about that? Well, the answer is we can either jack up that, we can increase companies tax, we can increase excise, we could try and fight for the sugar tax and the alcohol and other sin taxes. That's not our decision. That is a decision that the financial authorities take, and they have a particular policy that they follow where they do not like earmarked funding. However, we in health believe that you should still create the possibility of a payroll tax. Even if Treasury chooses never to use the payroll tax, but to use a mix of and a blend of the other taxes to move money out of what we're no longer going to need to purchase. Because if you drop off a medical scheme and you choose that you're only going to use the national health insurance, then you don't need to spend that money, or the portion of the money that is not paid for by your employer. You don't need to spend that money. So if you paid a portion of that to an increased tax, it may be a reasonable thing to do. How you do it, of course, is a whole nother ballgame. And that might take time. In fact, it will certainly take time. And it's not something that one would start with at the beginning of a process like this. So I'll end by saying that reform of health services are not events. They are journeys. They are complicated journeys. I don't think anybody who works outside of the health sector understands just how complicated the health sector is. We all know we work 24 hours a day, 7 days a week. And in the health sector, it never shuts down. And it's different from many other services that are provided because of that uniqueness. So you do not go and try and squeeze blood out of a stone, and you do not try and shift things too far, too fast, too many at the same time. You have to pick the sequence and do it gently and carefully so that we get to the end goal where we get equity and where we get the healthcare we need, when we need it, where we need it, without financial hardship. And I'm going to end there and take questions. Thank you, Ray.
Okay, thanks a lot, Nicholas, for that comprehensive high-level overview of NHI and health reforms. And you've indicated, I think, your closing remarks, that reform of health services is not an event, but a long journey. And you've just spoken about what happens in the UK, how many years they've been refining this. Just before we take questions, in our country, how long do you envisage that we'll have a system that will cover almost every citizen of this country through an NHI?
Well, I wish I had a crystal ball. I can tell you what I'd like, and I can tell you what I think. So what I would like is that in the next 10 to 15 years, when I'm in my old age home and dithering around needing chronic care, that I've got the system in place to look after me. So that would be the short term. In the long term, I think it's probably going to take longer than that.
Yeah, because I'm looking at we just had a workshop with the Office of Alzheimer's Compliance the other day. And there's intertwining of the accreditation of health services with NHI, and they're looking at 2024. So that's what would that be a medium-term plan or?
So 2024, Ray, and to the colleagues on the call, would probably be the start, not the end. So that's when you hope to start. So let's talk just a little bit. I didn't mention accreditation because it's in the process of getting the providers registered. If you want to be paid, you need to be accredited. You're all familiar with this in the private sector because you do it with medical schemes all the time. You need to be part of their group, or to be that they are comfortable to pay you. Then they want to see what you do. In the national health insurance, the conditions are slightly different. Step one is on compliance with some quality standards. Now, for most people in the private sector, most of those standards are not very difficult to achieve, but some of them are more difficult to achieve because they include patient records, which, by the way, are requirements in the Health Act, even for private facilities. And the way that some private facilities manage health records would not comply with what is in the Office of Health Standards Compliance. So it'll take a bit of time, even for some very beautiful and lovely and efficient private facilities to get compliant. In the public sector, there are some facilities which also sail through compliance, but there are others which for a long time are going to struggle to get through even that first step of compliance. So what we need to do is we need to have a stepwise approach. You can't just turn off and say some poor rural community or some poor urban community who's got a lousy clinic can't have healthcare. What we need to do is we have to start off by saying, for example, and this is what I said in Parliament on Tuesday, you have a self-assessment, and that self-assessment is what you get, what it shows on your report card, if you like, on our digital system that the public can see. You are not accredited, but you are allowed to continue because you've done the self-assessment and you have scored whatever the scoring is. The second step is where you get peer assessments. So outside of any conflict of interest, hospitals, clinicians, general practitioners would do peer assessments, and they would sign that who did the peer assessment, and that would become the second level of approval, if you like, rather than full accreditation. And only the third step would be where you get compliance in order to be accredited. In all three cases, you need to be accredited, because accreditation means your digital system is compatible, you have the staff to deliver the services, and we've agreed that you may deliver those services reasonably safely, even though you've got work to do on your quality. You know, we need to get real. As you heard, I've worked in 9 African countries. We need to get real. We are still an African country. We are certainly not the UK. We are not Germany. Germany, with the Bismarck system, has been busy since the 1800s building their health system. We're not even Australia or Malaysia. We're not Peru even. So we have to look at South Africa, and we've got to say, what do we do to make what we are trying to achieve achievable with the resources we've got, and not try and be silly and say, but in the UK this, or in the United States that. It's not a useful comment to make, and we hear it all too often. So I think we needn't be intimidated or threatened wherever you are in a practice. The aim is to get us all, everybody, to get a level of quality and accreditation that patients can know is satisfactory, and they're going to get good care.
That's quite reassuring, and I think most colleagues sitting here who are in the private sector GPs, they might be a bit apprehensive about what's going to happen. There's a question that has been sent to me directly that we'll deal with. Most of these questions are not clustered into themes, so we'll take them as they come, and you're free to answer them as you wish. How is the basic model of care going to be determined? That is, the protocols as applied by the PMB legislation is currently applicable in the private sector, the prescribed minimum benefits. We'll take each question as it comes here.
Oh, take each question as it comes. Okay. So at the moment, we've been busy unfortunately, COVID disrupted us quite a lot. But in the public sector, we've been busy with the primary healthcare package and the basic package of care for the public sector. We then engaged with the Council for Medical Schemes and said we need to harmonize, that the package is not vastly different from what is in the PMB. So the harmonization and the comprehensiveness of the PMB and the package in the public sector need to be much closer to one another. And many of your members will have been participating in some of those discussions, or certainly in the schemes, many of them have been participating in those discussions. You will have seen also a recommendation in the HMI report and in what the Council for Medical Schemes has been doing, where we would like to see all medical schemes having one basic package, that everybody can see this is common across all the schemes. So not to have the disadvantage where, as a non-medical person, even with the advice of a broker, you have absolutely no clue whatsoever what you are buying. So that first phase has been going on. As I say, it's been disrupted by COVID, and we'll pick it up again with Dr. Kobani and colleagues at the Council for Medical Schemes. But that's the first step in the process.
This one is interesting, from Esther Smuts. She says that I predict a total implosion of the South African healthcare system with NHI. I think this is quite, I'm sure you must have heard this quite a lot.
Oh yeah, no, that's what I was talking about, ideology. There are some who have ideology who say if it's not a free market system, then the whole thing's going to collapse. For those of us who are old enough, who were born in the public service, and our children were born in the public service, and we worked in the public service our whole clinical lives and so on, we've seen a public service that works. And there's no reason why it can't work again. The advantage we have, of course, is we've now got a highly competent private provider sector. The problem is that the financing of this whole thing is a mess, and it's not looking after everybody. And if you go and work in the places where I've worked in my life, you would say the whole health system imploded 20 years ago. So I don't know whose health system is going to implode. You may want to contact me separately after the meeting, and I can allay some fears, or maybe listen to what the detailed concerns are. You don't go about a reform like this in such a hurry that you light an what's the word, an ignition, a launt, a fuse. You don't go and light a fuse when you do things like this. You go slowly, and you build carefully so that you don't get implosions. But if you have concerns that you'd like to share with me outside of the meeting, that's my job. You're very welcome to contact me.
Yeah, I think the next question is related to that concept, that we've had a good split between the public and the private health system, and even in a functional tax-funded system that offered effective public health care. What has happened to that system? Where are those allocated funds? Why is it necessary to refine the system? And how can NHI be funded by even greater taxation of one of the smallest tax bases in the world?
Yeah, I don't know about the smallest tax bases in the world, but be that as it may, that's a very good question. And there are components of that question which could take a whole evening on their own. But let's look at some of the challenges of the public sector. I've been watching it from inside up to 2000 when I left the public service, and from outside since then, and worked on assignments in Treasury for 2 years where I got to see the money up close. So I can comment that it's complex. So part of it is the political structure through which the services are provided is complicated. So it's a constitutional federal fiscalism has definitely complicated our ability to deliver the service. I could go into how that has happened and what has happened. The second one is that the public health sector does not control its human resources, almost not at all. In some places in the public sector, well, first of all, the salaries are determined, negotiated, and designed outside of the health sector. And even when we tried to get involved, and there was an attempt to design new occupational specific dispensations, it became a free-for-all instead of what we were trying to achieve for a few scarce skills. And now everybody has occupational specific dispensations, including engineers and all kinds of other people. And the way in which that OSD has grown and changed shape has become expensive and difficult to manage. And it was supposed to replace RWAPs, the dreaded Section 30 of the Public Service Act, and it was supposed to replace limited private practice and all those horrible things that we knew about when we were young doctors. It didn't, unfortunately, and we now have an untenable situation where we spend 70% plus of the entire health budget on human resources. It's more complicated than that because of the overtime structure. It's complicated by the many allowances which have been negotiated and which are cross-cutting across the public service. And what happens is that when the bargaining happens centrally, any decision that is taken there is obligatory across the health sector, even if it's not appropriate. So, yeah, it's just been frustrating. So the human resources now consume, when I was a HOD, it was about 61 to 62% of my budget was spent on human resources. In Limpopo, it's now 71%. And it's not in their control. So the only way to cut that is to cut posts. So what we are doing at the moment, we have instructions, not from within the health departments, but from GPSA and Treasury and elsewhere, saying when a post becomes vacant, you can't fill it. So it's very frustrating. The hierarchy of management has been messed up completely. So for instance, a person like myself, who's the second highest rank in the public service, will be earning between 500 and 700,000 Rand a year less than I would be earning if I were a clinician in the same position with the same years of experience in the public service now. So what clinician, what public health medicine specialist in their right mind, what health practitioner in their right mind with a medical qualification would come and take a job? I mean, I'm fortunate. I'm retired. I just came back without, I don't really need to be where I am. So it doesn't matter to me. But to other people, a young person in their 40s and 50s who's climbing the career path, where's the incentive? So we go and train public health medicine specialists. We want them to get involved in management, and we pay them 500,000 Rand a year less than we pay their clinical counterparts in the same space. So for health, it doesn't work. And you will have seen in I don't know, those of you who watched this week, there was a public sector, I don't know what it was called, a big powwow with the minister and the DPSA and so on, looking at how to build a capable state. And this was raised by both the minister and the Director General of the Public Service and Administration Department. So that's the second big thing. The third one is the way we procure our products. So in the old days, the purchasing, certainly when I was a hospital superintendent way back in the 80s, purchasing of what I needed to run the services in that hospital was easy. I don't even remember it being any difficulty whatsoever. Now the tendering process and the way in which the delegations work and what you may and may not buy and everybody having to register, not with the health, but with Treasury as a supplier. Even when I worked as a consultant to government, I have to go and register as a consultant in the National Treasury database to be an employee in the health department. And I've been here 10 months now, and I still can't unregister off that system, no matter how hard I try. So there are frustrations like that that are outside of the health sector. I'm not trying to make excuses. You asked me what is causing the problem. And then capital works. This is a big irritation for a hospital manager in the public sector, because it's dealt with variously and differently from one province to the other. But in most provinces, it's the public works department or equivalent who manages the money. So the money is in the health budget for the capital works, but it is the agent, if you like, of the government, prescribed by that government, is the public works department. And you've seen it now with Charlotte Machecha Hospital, where our department nationally has had to go and take over that project and take it into the national department, because it just was not being managed by the works department in the province of Gauteng. So without pointing fingers at people, and I don't know other people's spaces, it's complicated. It is a frustration for a manager in the health sector. So systematically, over the last 25 years, we've put a noose around our necks, and we've just pulled it tighter and tighter and tighter, and we need to fix it. And many of those fixings are taking place in the public service, but part of the fixing is to get the private and the public sector to work more closely together. And I must pay tribute to all of you. Ray, you were one of them, colleagues who worked with us during COVID to make sure we were able to deliver this together. It wasn't that difficult, was it? So why can't we continue to work together? We don't want to take over all of the private providers. We just want the private providers to be paid for in a more consistent and comprehensive manner. And we need to fix a lot of things in the public sector. On the way.
No, thanks, Nicola. I think it worked, and COVID has taught us that it is possible. I'm sure it was simplistic, perhaps, but we did it, and we can still do lots more. There's a question from Arthur Manning, one of the most experienced public health sector managers, and he just has a few thoughts about public sector managers, that they're not conversant enough with NHI and not preparing for that, and also understanding the district health system versus the current district offices, legislation changes that are required, and the pace it's too slow. You've seen the questions. Any thoughts about that?
Yeah, very much, and I'm pleased, and thank you, Arthur, for raising them. You're absolutely right. So yesterday I had my launch meeting of my new branch in head office, and I've got a few staff so far. I asked them, and some of them are from within the department, and there are a couple of new people who will join from outside. So I asked everybody, do you all know what NHI is? I mean, they work in the NHI branch. And I think if there were 5 hands raised out of 80 people, that would have been a lot. So you're right, people don't understand. Even in the heart of the national department and in the provinces, people don't understand. And that is a big job. It's a big mountain to climb to do these kinds of seminars and webinars that we are having now in the public service. There are elements. First of all, we need the senior people, including the politicians, to understand the macro picture. Because even after reading the bill, and I spoke to somebody senior in Treasury the other day and said, why is it you guys have got something against NHI? And he said, I haven't even read the bill, and I'm not going to read the bill. So how can you comment from that kind of perspective if you aren't engaging with what we are trying to do? So, I mean, I pay tribute to you at clinics and others who have me on forums like this to come and share. But it's only when we get our team around us, because one Nicholas doesn't make an NHI, and one Dr. Tularia is one more. But, if it's 5 or it's 6, it needs to be hundreds, and it needs to be everybody understands. So Arthur's absolutely right on the first point. People don't understand what it is. They don't understand where it's coming, and we've got a lot of work to do to make sure. The story of the district officers. So today, there is a subcommittee of the National Health Council that looks after district health services and has for years. So today we had a meeting, and I was able to address them on what changes we see in the districts because of the National Health Insurance Bill and its impact on the National Health Act. So it will create 2 new major clauses in the National Health Act for the DHMO the District Health Management Office, which is slightly different functions from what happens in the provinces at the moment, and will expand to stewardship over the private sector within the districts, by the way. And then the contracting units for primary health care, which are much smaller units, which is where the private and the public sector service providers rubber hits the road in primary healthcare. So that too will now need to be grown, and there are some proof of concept projects where we are putting in money to do everything, not pilots, not little bits and pieces to test things, but putting the actual whole working system in place and using those as the learning centers for people to understand, because we can't do all of them at the same time.
You spoke about the products procurement, that there are too many shelves, items on the shelves. You said that, you don't even know, those patients, even in the private sector, what you're signing up for. Most patients can't even explain that. The same in the public sector. So how do we manage that?
Yeah, so anybody in the private sector can prescribe anything that SAHPRA has registered. So there are well over 100,000 products that SAHPRA has registered just in medicines, never mind medicines and biologicals, never mind the devices which we're still busy with in that environment. Nobody needs 100,000 different products. It's just crazy. In the public sector, we have about 20,000. Which have been selected over time and are part of the standard treatment guidelines and the formulary in the public sector, or what we call the EML. And we have a NEMLAC committee that when any medicine or biological is to be introduced or a company would like to sell it, we do an evaluation of the clinical evidence of the value of that new product before we'll add it to the public sector's essential medicines list. Only if they score on that will we do an economic evaluation of it to see whether it's cost effective. So take, for instance, this amazing COVID pill that's going to cure everybody. Well, first of all, the evidence doesn't show that it's much better than what you currently use for treating patients. And so we haven't even got as far as the economic evaluation. But in the States, it costs $3,000 a course. Who's going to pay for that in the public sector in South Africa? So you can register it, but at those kinds of prices, clearly it's not going to be useful to us in our market. But what we do need to do is code what we're having. And so we have been in discussion with the Medicredit and the NAPI code system and been talking to them about the coding of what's there and what's not there. We're not blind to what others have developed, and it's very useful stuff that we will be working with them to see what to do. But we also need health technology assessment to become real, not just a talk shop. So there are many companies in South Africa that are promoting health technology assessments. We have in our bill a requirement that we start doing health technology assessment. And we do have a measure of that in our NEMLAC and other processes. But we will be doing more with health technology assessment to choose the right products. So last comment on that, I had a webinar with one of the innovative medicine suppliers. I think it might have even been this morning. It feels like it was a week ago. And I said to them, yeah, there's lots going on. And they asked me, well, does this mean that the NHI will not procure innovative medicines? And the answer is no. Why would we do that? If the health technology assessment shows that innovative medicine is a more economically viable and a better technology to use, then that's what we must do. So I think we're open to anything.
Yeah, I think that is the next question is related to that, because the digital health strategy, you spoke about the patient records, the infrastructure that's going to be needed. How will you do that? Interoperability issues. And also, how do we get the healthcare providers to use the system in their own practices or even the health establishments?
Okay, thanks. So the bottom line with interoperable systems is you don't all need the same. So you don't all need the same software. You just need your software to be interoperable, and you need certain elements within the data sets to be common. So you need what we call a data dictionary. I'm not a data fundi, but I'll just explain what we are trying to achieve. So you need to all be talking about the same thing. So we talk about a data dictionary that you don't call an apple when I think it's an apple and it's a pear. And we need a common framework and the highway for us all to be able to do this. So we package patient data in blockchain. That's the technology, that's the route that we're going to make sure that it's not hackable. We also use a different specific protocol. So people who are going to be using this internet protocol on the fire systems, everybody will need to use that protocol, and so forth. So what's happened over a period of the year before COVID, so probably 3.5 years now, we have refined the original interoperability standards from 2014, and they were agreed to in the week before COVID, before the lockdown. They were agreed to, and we will gazette those interoperability standards. Everybody in the public and the private sector agreed to it. And as I said, the Health Information Exchange, that is it's Care Connect, which is in the private sector, and it's run as a not-for-profit organization by the private sector. They work on the same interoperability standards. Our service provider at the CSIR runs a laboratory where any vendor or any person who currently has a system can go and test their system against those interoperability standards. So we'll try and make it easier and easier for people to know that their systems are interoperable. So going forward, the hardware needs to match. So if you've got one of those nice big boxes that takes 2 people to carry out and you call that a screen, I'm sorry, your TV will be switched off soon. And the same is going to happen to you when we get to the digital world. But if you've got a cell phone, you can pretty much connect to the system. So we're not going to make it hard.
Will there be, public-private partnerships? I mean, you explained how the funding model will be the procurement, and also what patients you'll be servicing and who are the providers. But just for clarification in terms of about public-private partnerships.
Okay, so public-private partnership is a term that in our law is a dirty word for many government departments, because it's a specific process that's prescribed in law by Treasury. So we try not to talk about PPPs because it's defined like that in the procurement process. We rather talk about working together and collaborations and so forth. The health system will not work if we don't collaborate. And there are various spaces within the whole health system and different segments. We talk about the private sector. There's no such thing as the private sector. The service providers are not the same as the funders, are not the same as the suppliers of goods and services, and they each have different touch points with the health system, even now, never mind into how we want to organize it for national health insurance. So we all need to work together, but we have to find ways where the ultimate focus is on the patient. That's generally easier for the clinician to think about. But when you are listed and you have to feed your shareholders and you must make people happy, it becomes more and more difficult to do that. So it doesn't mean there isn't space for that. It just means we have to be more circumspect about how we work together and avoid conflicts of interest and so on.
Yeah, the next one is kind of interesting. It says now, we've got a report about the rate of unemployment, about 35% or so currently, and say, when we face in NHI it'll be 40%, so there'll be no tax base to support NHI. Yeah,
well, and I see that Estelle's asking about we are not England, but England in 1948. I wish you could see the video. I'll try and get it and send it to you if I can get it from the NHS. On the Friday, in Parliament, Bevan, who was the Minister of Health, who had previously been the Minister of just about everything else in the cabinet and was quite a brash gentleman, he stood up in Parliament and he thumped the desk and he said, the NHS starts on Friday. And then the newsreels pan to outside Parliament and the hospitals are bombed to pieces. There are bricks all over the place. There's still soldiers walking around. Some of the beds are in the street with awnings over them and so forth. And the NHS started on Friday. But that was 75 years ago. So you don't have to start with the final product. That's what I keep trying to emphasize. You start with what you've got and you try and get efficiencies in the system. And I've indicated a lot of those efficiencies. You don't need 75 boards of trustees. You don't need hundreds of people who are actuaries and others, each trying to think up a better program and a better product than the next one to get an efficient health system. You need that to be competitive, to make profit. But we are not talking about profit. We are not talking even about a tradable commodity. We are talking about a public good. And that's the mind shift we have to make.
Yeah, going back to the public sector, you know, when there were NHI pilots all over the country, and the question is, Mashadi Nong is asking, what happened to those pilot studies that we could be learning from in terms of...
Yeah, they're all published. So there was an independent assessment done of the pilot. There were 10 pilot districts and there were a number of pilot initiatives, some of which had some useful things and some very disastrous things that came out of them. But all in all, we either learned how to do something or how not to do something. So they were not a waste. One of those pilot programs was the ward-based primary healthcare system. We've learned an enormous amount about how to organize primary healthcare, the role of community health workers, where the GPs fit in, how to run group practices, etc. So not everything was wasted, but we also did GP contracting. But the way in which it was done was basically a 1 million rand a year subsidy to a general practice for something that was quite difficult to measure whether we got any value for money out of it. And we may have done better to employ community service doctors to do some of the work. So I'm being very negative about one thing on the one side and quite positive on the other side. The Ideal Clinic program was started, and a lot of facilities, well over 1,000 facilities, have now reached Ideal status. Ideal is a handle for a set of standards that are required of the management, the clinical care, and the physical environment within those facilities. So those reports are all available. I think they're all on the department's website, actually. I'll find out where they are. You're welcome to have them. And you will see for yourself that some of the outcomes were really not pleasing, and some were actually very good indeed.
Yeah. The next question is about the funding model. You've explained, I think, the different types of funding models, but the question still is, why do we have a single, I mean, from time you said that there's only one payer system, and it doesn't like your examples of RAF and COIDA. I said those are bad examples.
RAF and COIDA are very bad examples. That's why I'm going to get rid of them and bring the money into the NHI. Why don't we just get all our health service paid for from one place? So I'm not against that at all. I'm absolutely agreeing. You don't need all these different pools. That's one of our problems. You know, having how many risk pools have we got? At 90, something like 90 health risk pools. The Defence Force is separate. There's 9 provinces and the national. Then we've got 75 medical schemes, each with a risk pool. Then we've got COIDA and we've got RAF. No, it's messy. We can't have all these risk pools. And then the recommendation to have a risk equalization fund of the risk pools. Why not just have one fund?
Yeah, there's Dr. Muloko, confidence. I can't read the whole question. Perhaps if you just maybe make a comment, Confi, if you just want to make a comment, just maybe unmute yourself and because he's not happy that most of the questions are quite pessimistic, and they speak about the implosion of NHI. And he's got a view that's quite positive. Maybe someone who can, Confi, is it fine if you can just unmute yourself and just say a few comments?
Now, the question that I was asking there is that I've been listening to what we are, and good evening, everybody on the platform. I'm saying that I've been listening to the discussions as they are going, and I was saying the main thing that is happening at this point in time is the lawmaking process. We have the NHI bill that is before Parliament, and that NHI bill, what Parliament is doing is that it is translating that draft law into the actual law, which is the NHI Act. I would have, I assume that we as health professionals are all very familiar with the official NHI policy, which is the 2017 June white paper on the NHI. Now, listening to whatever that is being said, and nothing being said about the key activity that is taking place at this point in time, which is lawmaking, I just wonder. And if anyone says that the health professionals are not affair with the NHI, when about 5 years that the official policy has been adopted. By the way, the people in Parliament are not making new policy. They are making the law that will allow the adopted policy to be implemented. Thank you.
Thanks for that, Dr. Moloko. Thanks for that comment. Nicholas,
No, that's quite correct. Obviously, from my perspective, that's what I'm engaged with on a day-to-day basis at the moment. But I do understand that people, notwithstanding the white paper being very clear and the many documents are available, the video clips and so on, people still have anxieties. So I don't mind explaining the anxieties. But Dr. Moloko is absolutely right. What is happening at the moment is seminal in our reform of our health system.
Yeah, one of the public sector hospital managers is asking the question that, they seem to be struggling in the public sector with many difficulties. And I think we've been hearing a lot about what's happening at Charlottenburg, what's happening at Kosane Bara, that they seem not to be, not having sufficient guidelines to get those facilities ready. You mentioned that, we spoke about earlier on about accreditation, but the public sector hospitals, for them to be able to be part of the NHI, there's concern from the officials, the managers running those facilities, that there seem to be no guidelines to get them ready. Yeah,
so as we've heard, we lost 2 years with COVID where we should have been at this point already. It's the beginning of the process. And I guess that what Comfy has said a moment ago is really something we've got to remember. We haven't even got the framework of the bill finalized yet, never mind the getting ready. But during the pilots, a lot of steps were put in place, focusing on primary healthcare. So much of the primary healthcare strengthening has already started and is continuing. If you are not one of the 19 quality improvement sites, or one of the, I think, 197 facilities who are part of those 90 quality improvement sites in the National Quality Improvement Plan, then you haven't got, your turn hasn't arrived for this process yet. But for those who are part of those facilities, it has started, and we will then use those as the training sites for everybody else. Again, Rome wasn't built in a day, and it is coming. The discussions we are having with the financing and the finance structure, for example, for hospitals with DRGs, cost centers and so forth, has started in parts of the country. And for instance, in some of the big hospitals in the Western Cape, it's been, if you like, piloted very successfully and is working well. And in fact, it's not only the Western Cape, there's several provinces where it's working. And we will be able to roll out using those models.
And the next question from Dr. Clark, I suppose, is about getting the GPs involved, because from this question is that they are started to work in the clinics and getting contracts yearly, but there seems to be no implementation plan. How do you then move along with the GPs into preparing them for NHI? And being part that is something that I feel quite strongly about as well. So I'm really glad it came up, and I've done a number of seminars with the Family Practice Academy, with SAMA and the GP group there in SAMA, and the what do they call themselves, the network that works together, Morgan's crowd. Anyway, so so I've had many discussions with them over the last couple of years, even during COVID. So the question is, what's the role of the GP in the primary healthcare system? And what we are now about to embark on, remember tomorrow is the first day of the new financial year, we have converted one of our conditional grants, a national conditional grant, got a long name attached to it, where we will be using that money to implement, as I sort of briefly mentioned a moment ago, a handful of contracting units for primary healthcare. Now, inside a contracting unit for primary healthcare, every practitioner who wants to deliver services in the NHI will be an accredited provider, and then their role within that team of the contracting unit becomes clearer and clearer. And if one looks, for instance, at the model in New Zealand, the GPs that are within that district are organized themselves so that they're always on call and supporting the other primary healthcare services at a clinical level. But the community health workers also got a role to play, and they also need somewhere where they can send the people that they pick up when they do their house-to-house visits and so forth. So all of that
needs to now not be theory. We need to take the WABOTS program and implement it as a contracting unit for primary healthcare. And in that plan, the GPs have a critical role in clinical governance and clinical training. So I think it is coming. And if you're one of the few that are in the initial pilot projects, the whole world will be looking at you for guidance on how we're going to do this.
That'll be great. You mentioned accreditation of the private sector. There's a concern here from people in the market that, if we want to get the private sector accredited, are they currently doing something wrong that they need to be accredited? Why couldn't just let them be?
Yeah, they're doing lots of things wrong. Some of them are doing things where we should actually close the facility because they're breaking the law. And sometimes it's mostly not deliberate. People don't go out to try and break the law most of the time, but there are lack of compliance that are happening. I mean, in some of the discussions with GPs, there have been many GPs who've said they won't be able to meet the compliance standards of the Office of Health Standards Compliance. When I read them, I think, well, if you can't meet these standards, you shouldn't be seeing patients because even our clinics are better than that. So I think there are problems. Even in some very beautiful hospitals with lovely services in the private sector, where you feel like you're walking into a hotel and everybody smiles at you and so on. There are problems with the way in which the clinical governance works in that environment. And we work with the hospital groups when it comes to our attention, and we're talking to them. So there was a big debate about whether the private hospitals must have their own compliance standards. I said, on what basis? The National Health Act does not differentiate between a public and a private health establishment or a public or private hospital. So we would have to rewrite the law to enable us to have different standards. Why do you want different standards? If you want to have better and more standards, that's something you can do with one of the private accreditation authorities, and that's within your group, within your rights, and we would encourage that.
Yeah.
But the standards need to be standard.
Yeah, definitely. We need to, because the patient is at the center, and we need to make sure that we provide quality health care for the patient. We're running out of time, but let me take this one of the last two questions. I've skipped a few. Moving to nursing. Will there be a place for private nursing practitioners, or will you all have to be employed by government? Currently there are lots of nurses starting their own private practices.
Yeah.
Is there room for them?
Yes, there's room for them. There's room for private pharmacists, private optometrists, private nurses. It depends what you're doing. So if you've got a practice where you are doing, for instance, midwifery with home supervision and antenatal care, and even some of these practices do nursing care, deliveries and so forth. As long as they're registered with the Nursing Council, they have the appropriate training, the appropriate equipment, the backup from a hospital or an ambulance if there's going to be a problem, then they must be part of the network of the primary healthcare in the contracting unit for primary healthcare. So we are not promoting that a nurse becomes a doctor, and we don't want doctors to become nurses either. There's a role for everybody. You don't have to go and work in a public clinic to be a competent nurse contributing to the health of the patients. Yeah.
May I end with this question from Edward Musiamo, who says, from Charlotte McClark. Sorry to take you back, Dr. Crisp, is it going to be possible with implementing NHI, looking at difficulty in centralizing funding in NHI fund given the existing provincialized health financial system, insufficient progress in building capacity to manage NHI, the distrust of the private health sector, and slow progress in building a mixed delivery? That would be our last question then.
Yeah, thanks very much. So, I mean, obviously, reform is difficult, but some of us have been through this before. Those of us who were around in the 80s and the early 90s went through the transition out of the old government into the new one. My first job in the new South Africa was head of department of Limpopo province. We forget there was no such thing as Limpopo province. There was an office in Giani for Gazankulu. There was an office in Leboa Khomo for Leboa. There was an office in Tipotoyandu for Benda. And TPA had a little satellite office in Polokwane, Petersburg in those days. And the rest of it was in Pretoria. And within 1 year, we managed to get all those people to collaborate. a lot of unhappiness, a lot of strikes, throwing their toys out the cot and doing all kinds of things. But we got through and created a Limpopo department, which actually went through some very good years and had some very competent people who were running nice services there. And in fact, now the numbers of doctors and the numbers of services, clinics in that province is dramatically better than it was in 1994. So we forget and we don't give ourselves credit for the path we've come because we just see the problems. And I mean, I'm part of society. I'm a South African. I'm part of everyday life. I see these things. They irritate me. They drive me crazy. But I have a mantra, and that is, if you want to make noise, if you want to criticize, get in the bull ring and join us. Come and help us fix this mess. It's messy. We're not telling you everything's nice. That's why we want to create the NHI. We're telling you it's inequitable. It's unfair. It's unjust. And a lot of people do not get the healthcare that they need, or they end up in financial hardship, even when they thought that they had insured themselves. This is not okay. We need to fix it.
Definitely. Get in the bull ring. I'm going to ask Dr. Ernest Kinoshi, who's the Chief for Operations, Clinics Healthcare Group, to do the vote of thanks.
Thank you, Ray.
Thank you very much, Ray. And I think before I hand over to you to do the closing of the webinar, I need to thank Dr. Nicholas Crisp for having taken the time. I know we know how busy you are, Nicholas, in having made the time to be, first of all, to accept our invitation from clinics, but also to be able to address so many people. I think at one stage there were over 380 people logged in this evening. I think this has been time well spent for all of us. We know that you are a well-traveled public health specialist and also a policymaker extraordinary. And I think we really respect your views on many topics that you have handled in your life. I know that personally, and but also on NHI, because currently we know that you are the lead person, the lead official on NHI as DDG NHI in the Department of Health, and you are the minister's right-hand man, if I may say, on NHI. So we couldn't have heard it from anyone better than you at this moment. I think you have rekindled the debates and the topics and the interactions on NHI post the acute, I nearly said post COVID-19, but we know that it's not gone yet. But at least post the acute phase of COVID-19 in our country, I think NHI have taken a back seat, and now this is a time to start talking about it. I'm sure there are more people who would like to know more about the funding, the certification and accreditation of healthcare providers, not just the practitioners, the hospitals, the GPs. We spoke about the nurses and other healthcare providers who would need to be certified and also accredited so that they enter the NHI fund. But also the reimbursement models that are there for healthcare providers. So there's still more to talk about when it comes to NHI. We know that I think the way you've explained it, to me, it means that NHI will introduce a new health system completely in the country. We won't be, in a few years' time, I don't know how many years you spoke. We know that you said in the NHS in Britain, it's now 75th year, but we don't know when we will say that it is already established in this country, but the process has started. We hope that government will now push much faster on getting the NHI bill that Confi spoke about to become an NHI Act. We know that it's going to be one system. We may, in the near future, not talk about private health sector and public health sector anymore, but just one healthcare system. And I think whether we like it or not, we are moving that way sooner or later. Please continue to make yourself available to us and to everyone else in the public in the healthcare sector who may want to interact with you. I think there's going to be more and more interest in NHI after this talk. But I need to also thank everyone who had taken the time to log in today. Please continue to log in for the foreseeable future. Clinics will be hosting these free webinars on various topics in the healthcare sector. And actually, every Thursday at 6 o'clock for the foreseeable future, for as long as we can do it. There are so many topics, ever so many topics to address. We also invite you to suggest future topics, but also to suggest future speakers. You can contact any of us if you've got anyone who would like to talk or you want to suggest to be one of our future speakers, or yourselves sitting in here. I'm sure all of you have a lot to share when it comes to healthcare. But lastly, Ray, let me thank the technical team, the clinic's technical team that assist us every week with these webinars. Without them, of course, we wouldn't have these webinars. But lastly, just to thank you, Ray. You are our big webinar host and you do it so well. I think, thank you very much. Talking about you, maybe let me hand over to you to do the closing.
Oh, thanks a lot, Ernest. You've done. Thanks for those kind words, and thanks to Nicholas once more. And colleagues, and Nicholas has just shared generously the video on the NHS certificate beginning. So what we'll do, we'll share this with all those who logged in this evening. We'll take it to our technical team and send it back to everyone. And thanks for sharing that, Nicholas. We really appreciate that. And thanks, colleagues. And it was wonderful to be with you. And please do join us next week as we continue with these weekly webinars, and have a good evening.
Thank you very much, Ray.
Sure.